Sir, please send the tomorrow's link also.
Yeah, I will send.
Thank you, sir.
Okay, thank you. Okay, we will start now. So, good evening to all of you. Today, I'll be showing two short cases first before going to the proper case. Is my screen seen? Is it visible?
Yes, sir.
Yeah, okay, we'll start. This is a story of a 14-year-old male. In fact, he had an RTA 2 years back with head trauma and was on ventilator for 1 week. On recovery, he was found to have complete ptosis of the right eye and imbalance while walking. Patient gradually improved from all these complaints, but for one complaint that is persisting. His present problem, the complaint which was persisting since then was that he feels imbalanced while walking and feels dizzy while driving, especially when he shifts his gaze from one side to straight ahead position. He said this dizziness is not there all the time, mainly on walking or turning, or especially when he's driving. Suppose he's looking to one side of the road, suddenly shift his gaze to the front, he feels dizzy. And no history of an oscillopsia. That's the story of this patient. So nothing much in the history. He had an accident RTA, improved from all these things, except for he must have had a third nerve involvement because he had ptosis on the right side initially. The present problem is that he feels imbalanced while walking and feels dizzy while driving, especially when shifts his gaze from one side to straight ahead position. No history of oscillopsia. This is a discharge summary. Okay, this is the video, a short case only. His ocular movements were all normal. No restriction anywhere I could make out. Or jagged movement. And pupil was right is dilated, non-reacting. Left is also mid-dilated, but reacting slightly to light. But right side is not reacting at all. That's the finding here. Rest of the CNS examination is normal. This is the tandem walking. He could do it normally. Then I asked him to walk fast and turn around to precipitate his complaint.
Walk fast and നടന്നു ചുമ്മാ നടന്നു സ്പീഡ് നടക്കണം പക്ഷെ ഇത് പെട്ടെന്ന് തിരിഞ്ഞു നടന്നു Okay.
He said he felt imbalance while turning around. Not while walking straight ahead, turning around, he felt imbalance. So I made him walk fast and turn around, and he complained of dizziness when turning around. So what else you would like to do? What would you like to know in this patient? This is complaint. This has been troubling for the last 2 years. Any thoughts?
Sir, any positional distance or something, sir?
Yeah, no, I didn't. There's no nystagmus and no personal nystagmus also. He said on turning around in the bed, he did not have any dizziness. While traveling and suddenly turning, he gets some dizzy feeling. Not turning in the bed, he did not complain.
Sir, any relation with convergence, whether he is getting worse or better?
No, that he will not. He did not give that history. No particular problem in reading, he said. This is the problem, he said.
VOR, sir.
Okay, very good. VOR said that. So the first thing I thought in my mind was that whether he's got imbalance due to bilateral vestibulopathy. So I did what test will you do to bilateral vestibulopathy? That can present with ataxia imbalance, especially turning around.
Head
Head
impulse.
impulse test.
Yeah, head impulse test. So I did a head impulse test. That is negative. There is no effects of the labyrinth or vestibular nucleus. Head thrust is negative. What will you do now?
Subjective vertical visuals.
Okay, but he has no, yeah, but he has no tilt of the body or anything like that. The only problem is transient imbalance when it turns around.
Calorie testing will it help, sir?
Calorie test again, yeah, that's a good thought, but you already head thrust is negative. Okay, then
VOR
I asked
suppression,
you,
sir.
no, what I did was, no, we are suppressed also. It's got otherwise no other complaint of cerebellar involvement or anything. Pursuit normal, saccadic normal.
Is it due to the cranial palsy?
No cranial nerve at all. Absolutely no cranial nerve involvement. The only finding was pupil was dilated on the right side, not reacting. Left is normal, reacting sluggishly to light. So I asked you walk with one eye closed and then turn around.
നടക്കണം സ്ട്രെയിറ്റ് ആയിട്ട് സ്പീഡ് നടക്കണം.
He has no problem with one eye closed. Then what could be his problem? When you walk like that, turn around without by closing one eye, he had no dizziness. Only when he viewed with both eyes, he had dizziness.
Sorry. Superior oblique myoclonic liquids.
No, not superior oblique. Superior oblique produces oscillopsia or unioculair oscillopsia, the movement of the eye up and down.
Pupillary abnormality may be producing asymmetrical image falling on the retina.
Correct. That's important. See, always, every test you decide in neurology is not given in the textbook. You have to design according to the complaint of the patient. See, here one clue is that right pupil is dilated, non-reacting. Left is sluggishly reacting, but pupil is completely normal size. So definitely there is invariably measured cycloplegia also. Accommodation will also be failing on the right side. So when you're viewing from a near object to distant object or distant object to near object, naturally he has to focus your eyes also. When one is focusing, the other is not focusing, what will you get? You get a feeling of dizziness. The sudden change will produce even before the brain get accommodated, this transient change will produce a dizzy feeling. That is my interpretation. Now, so most likely dizziness is due to asymmetrical accommodation between the two eyes. When he shifts his gaze from one point to another, disparity in focusing between the two eyes. Not because of the pupillary dilatation, but because of the ciliary muscle failure to contract. But it's accommodation. The focusing become maybe defective.
So what was the cause of the dilated pupil?
He had a trauma. He had a head trauma.
Post-traumatic.
Yeah, he had a brainstem injury at that time.
Okay, sir.
He had a complete ptosis initially.
Okay.
And from the ocular movement and all, now left with only the cycloplegia was persistent. And
Okay.
So how will you treat him?
Sir, dilute pilocarpine, sir.
Yeah, exactly. That's what he did. So I put him and asked him to put dilute pilocarpine in his eyes, especially on the right eye. Then let's see the result. And then I did not come for follow-up. I'm sure he may be improved. I'll let you know the result later on. Okay, so the idea is to bring out, I mean, that the test we have to design is depending upon the complaint and the findings of the patient. Now I'll go to another patient, again a short case. This case is given by Dr. Srinivasan. Pardon?
How does the pilocarpine help in this case?
Because it will help the ciliary muscle contraction. If both are similarly contracting, nothing will happen. It is asymmetry between the two which causes the dizziness.
If the nerve fibers are damaged, will pilocarpine act?
That will act. Because actually it will easily act because the denervation hypersensitivity is there, no? So the pilocarpine will produce constriction. The pilocarpine will not act only if there is a pharmacological blockade. In all other situations, pilocarpine will act. Okay, shall we go to the next case?
Okay, sir.
Okay. The story of a 34-year-old lady. She presented with a 2 weeks history of unilateral headache, watering from the left eye and diplopia. No redness of the eye. Not a diabetic or hypertensive. This is the video of the patient. I will show the static pictures again later on. Eye closed, you can find the propers of the left eye, bilateral ptosis. Looking to the right side now, left eye fails to adduct. The left side, up, down. Up, down. Okay, I'll show the one by one static pictures. This is the picture showing bilateral ptosis more on the left side. And there is mild proptosis also. You cannot make out the proptosis a little better in this picture. Then this is on looking to the right side. You can see that both eyes are not moving to the right, especially on the left side is not at all moving, right side is moving a little bit. So restriction of abduction of the right eye and adduction of the left eye, left more than the right. Looking to the left side, again, there is restriction to both, I mean, in both eyes, but more restriction was seen in the left eye, again in the left eye. Restriction of abduction of the left eye and adduction of the right eye, left more than the right side. The left eye seems to have affected more. Then on looking up, there is a bilateral restriction. I couldn't obviously make out any difference. Then looking down, both eyes are not coming down properly, but left eye is, right eye is much more moving down, moving much more down than the left eye. So the restriction is more on the left eye compared to the right eye. So every restriction is more on the left side. So what is the diagnosis in this patient? Likely diagnosis. No other findings.
Sir, nuclear nerve palsy, sir.
It has got a restriction of all. Abduction also is restricted bilaterally, left more than right.
So was facial muscles normal, sir?
No, normal. Patient muscles are normal.
So
No,
bilateral ophthalmoplegia, sir.
yeah, correct. Ophthalmoplegia. What could be the possible etiology you can think of?
The duration of the total history is only for 3 days, sir.
10 days. 10 days history. 2 weeks history.
Probably
She had received some pain.
cavernous sinus thrombosis.
Yeah, that's a possibility. Good possibility one can consider. Can produce proptosis and ophthalmoplegia bilaterally. But she had no congestion or suffusion of the eyelid. I think they will congestion.
Left eye mild congestion.
No, it's not a very mild congestion. Right eye, there is no
Miller-Fisher,
congestion.
sir.
Okay, Miller-Fisher syndrome is a good possibility, but a proptosis is difficult to explain on the left side.
Tolosa and bilateral.
Bilateral Tolosa.
Tolosagand is also the possibility where you can produce all these things. She can explain the pain also, correct? Very good. That's the thing you have to keep.
Endophthalmitis, orbicellitis.
No, obviously is always unilateral into severe painful and patient with toxic. It's not orbital cellulitis. It's unlikely to be orbital cellulitis. Tolosagand is a possibility. Other possibilities are also okay.
Sir, what about the carotid cavernous fistula? Mainly,
Again, in carotid cavernous fistula and cavernous sinus thrombus and all, the classical finding there's a congestion of the eyes. In a CCF, you can cork-scribed vessels will be easily seen in the conjunctiva. Here, there is nothing like that. There is no only ptosis is there, proptosis is there.
Sir, thyroid
Otherwise, you
ophthalmopathy,
can.
sir.
Thyroid ophthalmopathy is a good possibility. So these are the various possibilities. What is it is correct. So what investigation you want? MRI, no?
MRI.
Okay, this is the MRI. I will show the MRI one by one. This is the T1. You can look at the orbital muscles there. This is the second cut of the orbital T1 weighted. I will show all of the Williams. This is T2. And the coronal cut. You can make out on the right side also all the ocular, extraocular muscles, and the left also you can make it out. Then SAG picture. So what is the diagnosis now?
So tendon is not involved, sir.
Yeah, tendon is not involved. Correct. Perfectly right. So
Thyroid.
Thyroid ophthalmopathy.
thyroid ophthalmoplegia, very good. That's the diagnosis. And you see here thyroid ophthalmoplegia. But you remember on this, usually the maximum affected muscle is what? Inferior rectus followed by the medial rectus. That is what you can clearly see here. See the medial rectus is bulky, quite bulky compared to the lateral rectus. That's a classical involvement of the thyroid ophthalmoplegia. And the tendons are spared, only the muscle middle is affected. If tendons are also affected with muscle thinking, enlargement considered pseudotumor of the orbit. Okay, so I think thyroid ophthalmoplegia, correct? You can make out the increased size of the medial rectus, lateral rectus, superior inferior rectus. Okay, but how do you explain the ptosis in this patient? Proptosis can be explained, everything can be explained, but ptosis, will you get ptosis in thyroid ophthalmopathy?
Maybe due to muscle involvement, restriction of movement.
Yeah, so will it produce ptosis?
So usually ptosis is rare, sir. It will not occur.
It will not occur. That is a peculiarity of restrictive ophthalmopathy, because restrictive ophthalmopathy was what? When the medial rectus is affected, the problem is abduction failure. Because medial rectus is infiltrated with the whatever is the pathology there, that will restrict the muscle from relaxing for the agonist to antagonist to contract. Suppose you want to the left side or to abduct the eye, the medial rectus should relax. But here medial rectus is restricting. It's not preventing it's not relaxing for the abduction to occur. That's called a restrictive myopathy, ocular myopathy. So he said thyroid is a classical example of restrictive ophthalmopathy. So if there is an infiltration of the LPS, what you're going to get is lid retraction, no ptosis. You will not get ptosis in thyroid ophthalmopathy.
is it associated?
Associated MG has to be ruled out.
Correct. So whenever you get ptosis in thyroid ophthalmopathy, think of associated myasthenia. Okay, because thyrotoxicosis can be associated with ocular myasthenia, and this is a case of a thyroid ophthalmopathy with myasthenia. So that's a clue is that you should not get ptosis in thyroid ophthalmopathy if it is a thing of myasthenia. Now, this is you can remember the mnemonic, I am slow. That is the order in which the ocular muscles are affected in thyroid ophthalmopathy. I for inferior rectus, M for middle rectus, S for superior rectus, L for lateral rectus, O for oblique. Oblique is affected last. So the typical distribution is inferior rectus muscle, most commonly affected, followed by middle rectus, superior rectus, sparing of the tendon sensations. So these are the order same order. Last is oblique. Okay, any questions before I go to the next case?
Sir, can we give steroids in this case, sir?
Yeah. The treatment of thyroid ophthalmopathy is steroid only. Steroid is the treatment. Sometimes it may not work.
Thyroid status toxic patient or euthyroid?
That part I don't know, because this case is not my case. Then this is Srinivas's case. He sent me the video.
Sir, good evening, sir.
Yeah, Srinivas is there.
Yes, sir. I am talking, sir. Sir,
Okay,
thyroid was normal, sir. That why I sent you the patient.
Okay.
Status was normal, but she improved with steroids.
That's a peculiarity to thyroid ophthalmopathy. Thyroid function can be normal, can be increased or decreased.
What about the anti-thyroid antibody levels?
Yeah,
these are not done, sir. Not done. These are not done.
Yeah. It's actually not the conventional antibody. There's some other factor that the thyroid, I forget about the factor that is elevated in these conditions. Responsive treatment is steroid.
Was pyridostig being given?
No, sir. Pyridostigmine was not given. She improved only with steroids.
Only with steroids. Okay.
So
RNS was positive. RNS was positive or negative?
No, we didn't do, sir. We didn't do the RNS.
So myasthenia does not require separate treatment.
No, actually, we do not know. Usually they require treatment. But we not got to keep the observation and follow up to find out what offers the doses. Because thyroid ophthalmopathy will not improve, the doses will not improve. Extraocular muscles will not improve. Okay, shall I go to the next case?
Yes, sir.
Okay. This is a 25-year-old man. In fact, he was admitted in our hospital with leptospirosis about 2 months back. He went into acute renal failure and had to be dialyzed. For dialysis, he was put on a catheter in the right internal jugular vein for about 1 week while he was in the ICU. 2 days after removal of the catheter, he developed pain of both arms, mainly on the right side, from the neck radiating out of the arm. He was shown to the orthopedician and he was diagnosed to have periarthritis of the right shoulder and was put on a plaster for next 2 weeks. On removing the plaster after about 2 weeks, he noticed that he was unable to lift his right upper limb. No weakness of the left upper limb. Around that time, along with the weakness of the right upper limb, he developed breathlessness. Courier paralysis of the right arm on leading question. Otherwise, he did not convey any numbness in any part of the body. A pulmonologist was consulted for his breathlessness, and he took an X-ray which showed right diaphragmatic palsy, which was confirmed later by fluoroscopy. So this is the story of the patient. I'll go back to the story once again. He had admitted leptospirosis in ICU, and he was on a cannula in the internal jugular vein. On removing the catheter, he developed pain of both arms, mainly on the right side. He was put on a plaster. On removing the plaster 2 weeks later, he noticed he was unable to lift his right upper limb. And developed, along with that, developed diaphragmatic palsy. In the summary, after removing the plaster, he was noticed to have upper limb weakness, proximal muscles upper limb weakness, as well as diaphragmatic palsy. Now let us see the examination findings now. I did the Sperling test was negative. Shoulder shrugging was normal. Deltoid normal on the left side. You cannot lift it at all. It's only just low power, it falls down. External rotation was weak. Internal rotation has very good power.
That's good power. ഇതിലോട്ട് തന്നിട്ട്
Brachioradialis was normal, biceps was weak.
anything which I found പൊക്കിക്കുമ്പോൾ
Wrist dorsiflexion was normal, finger extension normal,
മടക്കി പിടിച്ച
finger flexors are all normal,
ഒരു ഇതും പൊക്കിക്കും.
lower limb power all normal. The reflexes, right biceps supinated decreased. Triceps was on the viscous side. Left reflexes are all normal. Biceps supinated, normally elicited. Normally elicited on the left side. Knee jacks are brisk, ankle jack normal, plantar downgoing. Before his diaphragmatic movement, I couldn't make out any obvious difference between the two.
ഫ്ലൂറോസ്കോപ്പിയിലാണ് ഡയഫ്രം പലതും.
But fluoroscopy definitely showed diaphragmatic pulsing. Sensor examination normal.
ഇതൊക്കെ ഒരേപോലെ അറിയാം, ഇതൊക്കെ അറിയാം. പക്ഷെ ഈ കുത്തുന്നതും ഇത് വ്യത്യാസമുണ്ട്.
He is able to feel the sensation, but some uncomfortable sensation over the deltoid.
അറിയാം, ഇതോ
Vibration sense normal, everything is normal.
അറിയാമല്ലോ. കൈ മടക്കി
Left side biceps deltoid, everything normal on the left side. So right-sided, there is findings. This X-ray just showing the diaphragmatic palsy. Upper limb weakness of right deltoid, biceps and external rotators. Normal power of the internal rotators. Other muscles normal. Left upper limb normal. Lower limb tone power normal. The upper limb, right upper limb, biceps supinator just elicitable. Triceps is brisk. Left upper limb all normal. Sensory system normal except for some funny sensation over the right arm when the pain was tested. So that's a story of the patient. So where is, and he's got diaphragmatic also. So where is the localization in this patient and what is the likely etiology?
He has got the diaphragmatic pulse, sir.
On the right side.
On the right side. So
Right
there
side
is some, yeah. So as per nerve, it is the phrenic, but as per the root value is concerned, it is likely to be 345.
Correct, correct. 345.
And also we are getting the deltoid weakness. So C5 can be jolly well explained. And then also there is some amount of triceps bricks on the same side.
Right. Triceps brisk on the right side. Correct.
Right side. So this is likely to be a cord sign and also the root sign. So the likely anatomical site will be in the cervical region.
Yeah.
Or
cervical cord, intramedullary lesion. Which can
explain. And there is a history of catheter was there for a long time. After that, there was plaster. So some sort of an injury may be responsible for that.
Okay. So one localization cervical cord that can explain the involvement anticonal cells on the C3, 4, 5. Okay, that can explain most of the findings in this patient. Agree.
But triceps, the muscle power is normal. The briskiness can be due to weakness of deltoid. No, the biceps, no, sir.
Very perfect. Very good. So, very good. Perfectly right. His triceps power is normal. So, and the biceps is weak. You can have a spurious, brisk triceps. Okay, what your point is well taken. That's correct. So, we need not necessarily.
Another localization.
Pardon?
Another localization could be upper plexus.
Yeah.
Cannula-induced plexitis.
Pardon? Cannula-induced plexitis. Okay, but it is not confined to the plexus. Springtime is also affected.
Yes.
Radiculitis.
Oh,
okay.
Proximal plexus can have this diaphragmatic movement, sir. Proximal
No,
plexus.
it cannot. No, it cannot.
So, Parsonage syndrome
Many
can have,
person,
no, sir.
brachial neuritis patients.
Parsonage
Parsonage syndrome.
can
Yes.
have
Yes, that's a good possibility. Okay. Okay, these are the possibilities. All said correctly. So, what is likely injury to the brachial plexus? Well, this is the one you usually think of, no? Injury to the IV cannula of the brachial plexus. How to explain the right phrenic palsy? Is it possible that cannula has injured the phrenic nerve as well? Or was it a spinal cord lesion affecting the C4, C5, C segments on the right side? So this is a normal thing which you consider the possibility. Anyway, the brisk triceps also you pointed out that point. Is brisk compared to the left side. Okay. Now, see, if we look at the phrenic nerve anatomy, it's also close to the brachial plexus. This is phrenic nerve. So it's possible that a plexus injury here can also, or hematoma or something, can also produce a phrenic nerve involvement as well. So our question is now, is it inside the spinal cord? Is it in the plexus outside the spinal cord? So what other examination would you like to do?
Inner sign
So,
at the brachial plexus. Inner
rhomboids,
sign.
rhomboids.
Okay, correct.
Supraspinatus.
Okay, so examine for the rhomboids and supraspinatus. Let us see. It's no weakness of the serratus anterior. Again, no weakness of the serratus anterior. Check for the rhomboids. I supported him with his hand and asked him to push backward. There is no weakness of the rhomboids. So that means where there is a set of lesion. That means lesion has to be in the brachial plexus. It is not in the root. So it may be most likely the upper trunk is affected. Okay. Now, where is the brachial plexus? Upper trunk. Again, the question comes, how to explain the phrenic nerve palsy? So what is the likely etiology now?
Brachial neuritis.
Correct. Right. So any other examination we'd like to do in this patient? I want to know whether it's injury to the brachial plexus by the cannula, which can affect the phrenic nerve also, upper trunk also, or is it a brachial neuritis? I do not know.
Horner syndrome?
There is no Horner's. There is no Horner's. Horner's, we think of only lower root involvement, CAD1. Here there is no Horner syndrome.
Sorry.
Is some funny sensation on the deltoid, correct? That's not a very strong point. Okay. Now, I examined the left upper leg. Okay. One muscle is specifically checked. External rotators. External rotator is dorsally weak on the left side, see? But internal rotator is a good power. See, that's only muscle effect on the left side. Now, what is the diagnosis? Brachial neuritis. Right. Now, these are the things I will be showing some other cases also here now. See, in brachial neuritis, there is some vulnerability for certain muscles to, certain nerves to occur. And some of the muscles are curiously splayed. Why that is okay, we do not know. One such thing is that in a person with pain in the arm, we often do not look for infraspinatus. Frankly, no, we don't look for it. We look for deltoid, biceps, triceps, and then pass off. But you have to selectively look for this I have learned from my experience over seeing these patients. Some of them do have only infraspinatus affected. The patient comes with right brachial neuritis. We had problem differentiating is it a CFS root or not. You check the contralateral infraspinatus, they may be weak. That tells you your diagnosis is certain. Because why it's important? Because sometimes you may find a disc protrusion, which may be innocuous, may not be totally unrelated to our present problem. So here, this gives a clue that it cannot be due to disc disease. It is due to the brachial plexus. One more points which I have learned over the experience that I will tell you later on. This is neurologic amyotrophy. So what are the points favoring the same? If the left side is also affected, there is no problem in making diagnosis. And another point is, why do you look for the left infraspine? Because he initially complained of pain of both arms. That I told in the history. When the plaster was removed, he had pain of both arms, but more on the right side. This is bilateral. Often only muscle affected. Early neurologic amyotrophy infraspinatus before other muscles get affected. And what are the other points favoring neuralgic amyotrophy? One, he has got a sensory dulling of the right deltoid. That is another typical site of macular neuritis. And see the next video, which shows sensory dulling here.
അറിയാം ഇതൊക്കെ ഒരേപോലെ അറിയാം ഇതൊക്കെ അറിയാം പക്ഷെ ഈ കുത്തുന്നതും ഇത് വ്യത്യാസമുണ്ട്
Is it able to feel? But some funny sensation there that I compared with them.
മാത്രമേ ഉള്ളൂ.
Other clues. The other finding which I have observed in neurologic amyotrophy is that the brachioradial is often spared in the face of affection of other muscles supplied by the upper trunk. Now, if you have gone through seen your own patients you have seen over years, the maximum affect muscle will be deltoid and then infraspinal external rotatus. Then it will be biceps will be affected. So all pointing to an upper trunk, but the brachioradial is often spared. Most of the time spared. Why it is spared, I don't know. But that is the finding you get in neurologic amyotrophy. See the next video of this patient. It's got significant weakened deltoid and biceps, but the brachioradial has got a good power. So that thing again tells you that it is not an injury or a focal structural pathology affecting the brachial plexus. Okay. Any questions in that case?
So in C5 radiculopathy,
Yeah.
If the rhomboids are normal, can we rule out a C5 radiculopathy? Is it invariably affected in?
No, if the muscle which invariably should be affected in C5 root is rhomboids. That is a segment pointing muscle of C5 is rhomboids.
So if rhomboid is normal, we can rule out.
You can rule out C5 radiculopathy.
Thanks.
In the presence of a weakness of deltoid, rhomboid should invariably affect it.
So what is the explanation for the contralateral muscle getting involved?
It's because brachial is often bilateral. Because that is why they combine bilateral pain. Or there may not, other weakness may not be there. Unless you look for it, you may not pick up the weakness also. I have seen patients coming with only pain on one upper limb. No complaint on the opposite upper limb, but he found infraspinous weakness there. I will show, I bring the video another case this time.
So here the diaphragmatic weakness is due to separate involvement of the phrenic.
No. This is also another picture. I will be showing some other cases now. See, in brachial it is not brachial neuritis, it is a misnomer, total misnomer. Because the affection can be only one nerve, because they can come with only long thoracic nerve producing winging of the scapula. They can produce trapezius muscle involvement. They can produce only diaphragmatic nerve palsy, diaphragmatic palsy. Only phrenic nerve palsy, without any other upper limb involvement. And if you get a combination, well and good, diagnosis is almost set. So that's one of the common accompaniments of a brachial neuritis. This is the third case I'm seeing with the brachial neuritis with the diaphragmatic palsy.
Sir, was steroids given in this case, sir?
Yes, steroid is given, is much better. The other patient who had diaphragmatic palsy improved, but not totally. All upper limb for all become normal. Diaphragmatic paralysis improved, but not. He was initially breathless. That all disappeared, but still he is telling that on climbing upstairs, mild breathlessness is still present.
So past dose was given or routine 50 milligram was given steroid.
I usually only in severe cases I give one. I am loading dose of 5 methylprednisolone. Mild weakness only oral steroid. That is up to you to decide. Some of them made with steroid do not improve also if you come late.
Sir, oral steroid for how many days, sir?
So it's all arbitrary, all arbitrary. Usually 2 to 3 weeks a week and then taper it down. See, if
the patient are present late,
yeah, they will not. They will not. But even if they present late, the steroid may not work. They go on improving over a period of time. Some people it will be left with permanent wasting and weakness. They do not improve. Some they improve. Most of them do improve. Some may not be complete improvement. Some may be partial improvement.
IVIG, Any role?
IVG, I do not know. I have not given IVG for brachial neuritis. Even diabetic patient also, I give only steroid only.
If the patient presents within a period of 5 days with the symptoms,
Yeah.
and
Yeah.
clinically this is like what is the investigation by which we can confirm like it is only clinical diagnosis or any investigation we can do for supporting the diagnosis?
That's a good question. Nowadays, there is some MRI abnormalities and described in brachial neuritis. There is a twisting of the nerve and all. And that I will show the picture later on. I do not know much about those things. There is some common one literature is there in regarding that thing. But it will not, again, that is, we are not sure that is confirmatory to that or not. It is largely clinical diagnosis and exclusion of other possibilities.
Any role for EMG?
Yeah, of course, to localize, we can to do EMG. Now, I will show 2-3 cases then because this I'm going to show similar cases. Okay, then wherein I had an EMG also. Okay, I'll go to the next case, 2-3 cases. Another case. This is a story of a 24-year-old female. She presented with difficulty in elevating the arm and difficulty in putting food in her mouth for the 14 days. This occurred after delivery. No history to suggest any distal muscle weakness. No pain or paresthesia. She was admitted here and was given IVB for 5 days with minimal improvement of the right upper limb. It's only 5 days. 2 days after discharge, that on the 7th day after the upper limb weakness, she noticed some clumsiness of the right foot while walking and got admitted. So this is the video of the patient. This is the initial affection on weak back. Deltoid was weak. Biceps was weak. Biceps was normal. Okay. External rotation, the left side is normal. That is weak on the right side. Internal rotation is normal. You can see the breaker release good power. Distal muscles are all normal. Okay, see the left lower limb power proximal normal. This is normal. He had mild weakness of dorsiflexion, almost normal power, but the maker gait will CHL was weak in this patient. That is weak on the patient. He is weak. Plantar flexion normal. Inversion was normal, but inversion was mildly weak, very mildly. That is mildly weak. Hip extension normal. Biceps supinated, it is decreased on the right side. Triceps is now, triceps also is decreased on the right side. Eject is very receptible. And eject normal. That's also normal. Consistency examination was normal.
ഒരേപോലെ അറിയാവോ ഇത് രണ്ടും ഒരേപോലെ ഇതറിയാവോ കിരികിരിപ്പ് കുറന്ന് അറിയാമല്ലോ ഇതറിയാമല്ലോ ഇനി കാല് നേരെ പൊങ്ങട്ടെ ശരി മടക്കിക്ക്.
Now look at the way she walks, almost normal gait, but she cannot walk on heel. On walking on heel, the forefoot comes down compared to the left. That's a weakness. You can walk on toes normally. So right upper limb weakness, right deltoid, biceps infraspinatus, other muscles normal. Left upper limb normal, right lower limb weakness, right THL. Mild weakness of right dorsal plexus, everters with the normal power of the inverters and plantar plexus. She could not fully dorsiflex the right foot while walking. Left lower limb normal power. Right bicep supinated tricep decrease on the right side. Left upper limb DTR normal. Both knee and ankle jacks are normally elicited. Sensations are normal. So this is also a brachial area. This is the first conduction done in this patient, the right upper limb. It was normal. Very often in brachial neuritis, if you do conduction, it may be normal. Because mainly it is an axonopathy. So it will come appear, appendix may appear only later on. So this is all normal in this patient. But it's only 1 week after the sensory condition was done, within 1 week. Now, the second NCS was done on 23rd July after when the patient had right lower limb weakness. See, she has got a conduction block there in the right peroneal nerve. Rest of the findings normal. Sensory system all normal. F8 normal. So what is the diagnosis now? Again, another case of neuralgic amyotrophy is presented. Now is come with foot drop, conperoneal involvement. Within 1 week, it has affected the right lower limb. This is again one type of presentation of brachial neuritis. Not brachial neuritis, neuralgic amyotrophy.
So can there be a conduction block, sir?
There can be conduction block also, because it depends upon the pathology. Most of the time it is axonal involvement. That is why you won't get any finding. Some of them do have conduction block. And those with conduction block, the improvement is dramatic. Very well they improve. Those with axonopathy, the improvement is very, that is why they come with wasting and all later on. The prognosis is not that good. I'll show you 2-3 cases then. Yeah, please.
So was there any pain, the severe pain later on and continuous in the lower limb or something, right? Upper limb she had pain.
She had pain. Right lower limb, no pain at all.
So
she had no pain.
So whether like this paranodopathy kind of pain.
Yeah, it's all
or some subtle variation of GBS like presentation.
Yeah, you always know the neuralgic amyotrophy or demyelinating type, whether it is a focal type of an ADP, focal type of a CADP is always a problem. Because it's an overlap between all these things, multifocal motor, the conduction, everything will be overlapping. It's only in the terminology.
Understood, sir. So have you given treatment? She improved further. What treatment that you have given, sir? Initially, steroids, she didn't have that much improvement in the right upper limb.
But it's only 1 week. Now, the problem is that she was given steroid, but it's just 2 days after the steroid only came with the right lower limb weakness. Only 1 week now. We do not know the
1 week.
Just 1 week. Otherwise, I have gone for a second type of immunomodulator treatment. Yeah.
Is it an autoimmune pathology?
Pardon?
Is it an autoimmune pathology related to pregnancy?
No, there are many precipitating factors for neurologic amyotrophy. One, any trauma or any accident, surgery, anesthesia, pregnancy. These are all precipitating factors in neurologic amyotrophy. And some injections. But why that is occurring, we do not know. But this is very... even trauma is also a very common problem. Why that occurs, we do not know. Pregnancy is very notorious to cause neurologic amyotrophy.
So what about prognosis?
What about?
Prognosis, sir.
Most of the time, the demyelinating type prognosis is very good. But in those with axonal involvement, some of them do, if you give treatment early, some of them do go very well. Totally unpredictable. Some of them do not do well, even if you get treated early.
Sir, any other treatment option other than steroids, sir?
That we have to look into the literature. Logically speaking, other immunomodulator treatment can be given, like IVIG and other things can be given. But I do not know. I try to search the literature, find out whether they are given other modalities of treatment. Okay, I'll show 2-3 cases. Then I will discuss later on.
After she was admitted for the second time. Hello, sir?
Yeah.
Sir, when she was readmitted,
Two
what
days.
treatment was given, sir?
Yeah. In fact, she came here 1 week back, 10 days back. At that time, she had upper limb weakness. She was given 5 days IVIG and then discharged here. 2 days after discharge, came back again with a foot problem. And they were attributing it to the injection she had allergy. That's the complaint they were telling. So 2 days after the discharge, she had allergy. Then that is just, in fact, the disease evolving.
Sir, is it vasculitic neuropathy, sir? Vasculitic neuropathy possible?
Yeah, that possibility has to be considered. In the second patient, we investigated for a vasculitis, all were negative.
So
And look
sorry,
at the pattern of involvement in the muscle in the upper limb. That is very classical of a neurologic amyotrophy. That is deltoid by it's a classical presentation. Deltoid biceps and intraspinatus. Yeah.
second time, what treatment was given, sir?
Nothing. We did not give anything. Just to come because we already given steroid. We wait for some time the effect to come. That's the thing. We did not give any other treatment. She's asked to come for follow-up after 2 weeks. Okay, I will 2-3 cases. I will similar cases.
So one question: why is it called amyotrophy? Because there is no wasting in the muscles, no?
Usually, the neurologic amyotrophy, there is a wasting, acts on a usual time.
Okay,
but
that is chronic cases.
Yeah, that's a chronic cases. But what is that is need not necessarily should not be called amyotrophy. Because the original name is brachial neuritis. And I'll give 2-3 cases of these similar cases, then I'll come to then you'll understand why the disparity, the problem with the terminology sent on.
Okay, sir.
This is a 13-year-old man presented with history of inability to lift his fingers with the right hand. This is complaint. That's only complaint, 1 week duration. See is tone was normal, deltoid normal, biceps normal, biceps normal, brachioradial is normal. Left upper limb, everything was normal. Look, he has got a complete finger drop. Western oscillation is normal power, but finger drop is 0. That is normal on the right, left side. He cannot lift it at all. And maximum for the middle 3 fingers. And look at the thumb, he is able to extend. See? The same nerve is supplying all the things, but the extensor pollicis is weak, but not as weak as the other fingers. See, that is at least 4 power is there. That is on the left side. That is mildly weak. And abductor pollicis longus is normal even on the affected side. The abductor pollicis longus. See, the power is good. Extensor pollicis is mildly weak, abductor pollicis, everything supplied with the same nerve.
ഇതറ്റം അകത്തോട്ട് മടക്കി ഇങ്ങനെ അറ്റം മടങ്ങാതെ ഇങ്ങനെ പിടിച്ചോ. ശരി, അതേപോലെ ഈ അറ്റം മടക്കിക്കേ. ഈ വിരലിൻ്റെ അറ്റം മടക്ക്, ഇതിൻ്റെ അറ്റം മടക്ക്, മടക്കിക്കേ. ഈ തള്ളവിരലിൻ്റെ അറ്റം മടക്ക്. ഇനി അറ്റം മടങ്ങാതെ ഇങ്ങനെ കൊണ്ടുവരണം. വെരി ഗുഡ്. അതേപോലെ വെരി ഗുഡ്. ഒരു സമയക്കരുത്. ഇങ്ങനെ പിടിച്ച് ഇങ്ങനെ പിടിച്ചു.
Normal.
ഇങ്ങനെ വെച്ചിട്ട് ഇങ്ങോട്ട് തള്ളു.
That is normal.
ഇനി ഇവിടെ തല വെച്ച് ഇങ്ങനെ പൊക്കിക്കാൻ മുന്നോട്ട്.
See, resection is good power.
ഇതും പൊക്കിക്കാൻ വിട്ടോ. പാദം മുന്നോട്ട്.
Lower limb examination normal. The reflex is normally elicited.
ഇത് ഒരേപോലെയാണോ? ചെറിയ വ്യത്യാസം പറ്റും.
Yes, some dulling of sensation, the web space between the thumb and the index.
കുത്തി വരുമ്പോൾ എന്തെങ്കിലും വ്യത്യാസം ഉണ്ടെങ്കിൽ പറയണം. ഇല്ലല്ലോ, ഇല്ല ഒരേപോലെ അല്ലേ?
Yes, it's almost normal.
ശരി, കൈമലത്തി വെച്ച് ഇതൊക്കെ ഒരേപോലെയാണല്ലോ. ഇപ്പോൾ ഉണ്ടല്ലോ ഈ ഇപ്പം എങ്ങനെയാ?
Joint sense also normal.
ഇപ്പോഴേ എഴുന്നേറ്റിരുന്നു. ഞങ്ങൾക്ക് പെയിനൊന്നും ഇല്ലല്ലോ.
അതെ അതെ.
So weakness of extensor pollicis longus and brevis grade 4 and other finger extensions grade 0 to 1. Grade 0 for middle two fingers and grade 1 for middle index finger. All other muscles normal, even those separated by the posterior interosseous nerve are normal, apart from these muscles. DTR are all normal, sensory system normal. So where is the site of lesion? Posterior interosseous. Posterior interosseous nerve. Okay, partial affection. But all of the muscles separated by the pin are spared. How is it possible? If you think of a nerve in this is pardon?
Certain fascicles are
correct.
because of the fascicular.
So that in the fascicular vulnerability means some of the nerve fibers are more vulnerable. But here it is not like that. Even in one nerve, one muscle may some of the fibers supplying that muscle may be affected. That is why if you got, for example, in the suprascapular nerve, it's supplying supraspinatus and infraspinatus. But because sparing of the supraspinatus separate to the infraspinatus. So that's a peculiarity of this kind of a disease. Now I'll show 2-3 cases also. And nerve contraction was done, that is normal. Snap normal, FF normal. Then is it a cortical hand now? This particular finger fixation weakness, extensor weakness. This particular patient. What will you do now? There's no sensory, only finger extension is markedly weak, not conforming to a nerve pattern or a root pattern.
Extension of distal interphalangeal joints.
Pardon?
Extension of distal interphalangeal joints.
I didn't get even weakness of the
weakness of the you have to check the weakness of the extension of distal interphalangeal joint, sir.
Yeah, that's totally weak. See, all the finger, even the finger extends, the metacarpophalangeal is weak. The distal interphalangeal is normal. That is why I checked in the I did like this. No, that is normal.
That will
will
differentiate from cortical lesion. That was the telling.
No, that can't differentiate. In fact, cortical lesion, the first maximum effect will be the thumb. Thumb will be affected. Sometimes it can be confined little finger out. These are all described. Partial affection of the hand muscle can be affected in cortical lesion. That is described. In fact, remember a patient. Pardon? They can come with the foot. Yeah, pardon?
Shoulder abduction.
Yeah. Here, shoulder abduction is normal.
Normal. So
dexterity can be dex.
Pardon? Can you tell that once again? In a cortical lesion, you can have selective involvement of some other muscles. See, some time back, remember one patient I had shown only the thumb is affected. Then I had a bad experience in which I diagnosed a radial nerve palsy in one patient. He did not improve, but he insisted on MRI. Then I said, no, it's not required. It's a typical case of wrist draw. Then he took an MRI by himself and showed the infarct, particularly infarct producing wrist draw. You can have a cortical foot draw, cortical wrist draw. These are all described in cortical lesions. Especially when there is no sensory, always keep that possibility in the back of the mind if it is acute in onset. And without pain in the limb coming, you have to think of a cortical lesion. Suppose pain is there in the limb, more likely to be a peripheral problem. See, here I am not sure it's a cortical lesion or not. He has no sensory. The findings are not conforming to a nerve pattern. Then how can you say that it's a pin involvement? I'm not sure. So what will you do now?
Can be checked, sir.
Pardon?
Dexterity, sir.
But already if the weakness is there, you can't, no point in checking dexterity.
But flexion is strong, extension is weak.
Yeah, but that's a pattern you get in pyramid lesion also. Extension can be more weak than the flexion. Dexterity you can check only with a relatively good power. With weakness is there, there's no point in checking dexterity. It will be lost invariably. Here is 0.
Pronator test.
Pronate, if there is spasticity, you can look at pronator, but that is not positive in cases of a focal infarct like this. You may not get any features of spasticity in the upper limb. They come with a wrist drop only or a foot drop only.
But if it is a cortical lesion producing the wrist drop, while a particular hand area is affected, will that other muscle groups supplied by those areas get affected?
That's a logical answer you have given, currently logical answer. But the thing, remember that in cortical lesion, this kind of various patterns are described. You can have only finger extensions weakness. Only I'll show you next week. I'll show you a cortical.
You have shown previously also.
Right. Only the thumb muscles are all affected. Nothing else. I'll show you another person with foot drop only. Nothing else. Get a cortical paracentral infarct.
Since you told all our related brachiplexus lesion, then put it on film. Otherwise, we had shown similar piece before also.
Okay. So here, what should I do to roll a cortical lesion as a practicing physician? Want an MRI here or something else?
MRI.
No, I did an EMG. If EMG is there, that's enough. We can save the money for an MRI. Okay, so see the EMG from the extension digitorum. It's got denervation pattern, the denervation in vasculations and fibrillation potential of the extension digitorum on the right side. So that tells you lesion is in the periphery, not in the cortex. Then incomplete interpretation. Then it is from the normal side on the left side for comparison. No spontaneous activity and normal recruitment and complete interpretation. So it shows denervation. So diagnosis and neurologic amyotrophy. Now I'll show another case. This 17-year-old man came with the weakness of the right hand on getting up in the morning, 1 week back, no other complaint. His complaint is only one complaint. Sir, when I got up in the morning, I could not put my dhoti. That's the story here said. See, I could not tie his dhoti with my right hand. That is his complaint. But examination did not reveal any weakness. Let us see. He said I couldn't tie the dhoti. That's his complaint. No pain, nothing. Deltoid normal. Sensation normal. Good power. Finger extension is normal. Maximum pidicho. That's also good power. Or finger flex is normal. Maximum okay. Then no sensory involvement. Reflexes are all normal. Sensation normal. Then what is causing is difficulty in tying the dhoti.
did he have thumb weakness? Thumb weakness.
Exactly.
Thumb
Because
is very important for dhoti tying.
yeah, right. For putting dhoti inside, no, you need thumb.
Flexor as well as extensors.
Yeah, thumb is the one which is important. So MRI brain was normal. They came with MRI. The sensory is, I forget about that thing. I'll skip in the interest of time. See, this is the thing you look for. Certain things, hands are helpful. See, this is the test you do. See, that he's got a pointing thumb sign. Pointing index sign is for index finger. The thumb is weak. See, I can easily overcome the thumb. If I have not done this test, I would have missed this thing. That is on the normal side. That is weak. That is flexible. Brevis is weak, normal. Extension is weak. Now the longus is weak. See, that's weak. Flexible is longus is weak, brevis is normal. So where is the site of lesion here? I'll show that part once again. See, that is extra and body is longus. That's checking the brevis, that is normal. Only longus is affected. Anti-introsus nerve. Correct. But anti-introsus supplies the flexor digitorum profundus of the lateral to this thing also. That is paired. Flexor digitorum sublimis. Lateral two are also separated by the anti-introsus nerve. How do you explain that thing? See, it can rarely occur as entrepreneur, more often it is a variant of present brachial neuritis. I think I'll skip that thing. Now you see, the involvement may be only one branch of the anti-introsus nerve. And if you go to the literature, flexor pollicis longus muscle alone may be affected in brachial neuritis. Alone may be, not my, this is not my own this thing, given in the textbooks also. This is one presentation of neurologic. We can spare all, just like the previous patient who had a radial and a posterior interstitial involvement, only muscle affected extensor digitorum and mind involvement extensor pollicis. Abductor pollicis longus is normal. Restriction is also normal. I'll show another case, a 28-year-old female. Her complaint started as inability to elevate or extend her left thumb. She said even if she is a dancer, she could not make a mudra with the left thumb. This case I shown you earlier while she was doing a dance practice 3 days back. She also noticed that she could not pleat her hair of her daughter when she was trying to do the hairdressing. No pain, no paresthesia. Let us see this patient's finding. Those things I will skip in the interest of time. Flexor pollicis long, brevis is normal. Abductor pollicis longus is normal. Normal. Finger abductor is normal.
Maximum തള്ളിപ്പിടി 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 ഇങ്ങോട്ട് തള്ളിക്കാം തള്ളിപ്പിടി തള്ളിപ്പിടി വിടല്ലേ വിടല്ലേ അത് തന്നെ അതുവരെ മടക്കിക്ക് നൂർത്തെ 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 ഇത് കൊണ്ടുപോവാ ഇത് കൊണ്ടുപോവാ സമ്മതിക്കരുത് പിടിച്ച് പിടിച്ചേ ഊരാൻ സമ്മതിക്കരുത് തള്ള വരല് വരരുതേ
See the left, look at the left thumb, it has gone down. He has got a thumb drop, not finger drop. Usually you get posterior, now you get finger drop. Your thumb drop is there, only no other thing, no drop for other fingers. Sensations are normal. That is normal. The only finding was, I think at that part I skipped, I think. I'll show that. See this one, and this is the part in fact, I'll show that part once again. In fact, I forwarded fast.
Action പിടിക്കണേ പിടിച്ചോ ഇത് പിടിച്ചോ
Now look at the thumb on the right side, normal. That's normal. And you look at the left side. That's also important. Now look at the left side. She could not elevate it at all. Extensor pollicis brevis is weak. Longus also is weak. He could not extend the distal phalanx. Flexor part is normal.
Very good.
Good power. Flexor pollicis brevis normal. All the thing normal. So she has only weakness of the extensor pollicis longus and extensor pollicis brevis. It's not extensor hallucis, extensor pollicis longus, extensor pollicis brevis. And she has not only left a thumb drop, no finger drop. Sense system all normal except for the number. She also had some numbness over the small area in the web space, but there is no sensory loss. I think I'll skip all these things. NCS was normal, and NCS showed there is a conduction block in the radial nerve, the EAP. It is 9, and this is another case. And within 2 weeks, she improved. So only oral steroid was given. After 2 weeks came that she became entirely normal. So in summary, the clinical picture of neuralgic amyotrophy is very diverse, as a large variety of nerves can be affected. Inflammation seldom occurs in the brachial plexus itself, but mostly in the radial and distal branches. For this reason, the term brachial plexitis has been largely abandoned, with others proposing more accurate descriptions of the underlying pathology, such as mononeuropathy or multiplex. In rare cases, nerves which are not related to the brachial plexus can be affected, such as phrenic nerve, cranial nerves, or even lumbosacral plexus. This is from the literature. This is after the treatment. See, the conduction block is totally reversed after 3 weeks. This is after repeat conduction. Let me see. I think I'll stop here. 2, 3 things. This is the thing I wanted to mention. I will just show that thing also. Now, somebody asked about the pathophysiology of neurologic amyotrophy. Any other test which you can do. See, large reports from neurological centers show distinct classical patterns of muscle weakness, commonly affecting upper plexus nerves such as suprascapular, long thoracic, musculocutaneous, or axillary nerve, most frequently in some combination. However, experienced surgical units focusing on the occurrence of HCL mainly report isolated pulses of nerves such as AIN and posterior nerve. And this is the one, the abnormality they have detected. That is schematic visualization of the theory of constriction and torsional development in neurologic amyotrophy is postulated by some authors. This is from literature only. This is from the MRI. They can pick out this kind of a kinging of these nerves in neurologic amyotrophy. This kind of a torsion, twisting of the nerves. The typical clinical person neurologic amyotrophy involves lesions of a brachial. We're going to about that. 3D neurography has performed in such cases, including a curved multiplanar reconstruction of the long thoracic nerve from a highly T2 weighted fat suppressed, which revealed hyperintense thickened nerve with multiple hourglass-like constrictions. That is the finding they detected in neurologic amyotrophy, some of them. Whether this can be routinely done or not, I do not know. This is from the literature only. Okay, so my aim of a talk was that this neuralgic amyotrophy can vary type of presentation, may not necessarily be in the brachial plexus. Only part of the nerve can be affected, just part of the nerve. The anti-inversus nerve, it may be only affecting the flexor pollicis longus. In the posterior inversus, it may only affect the extensor pollicis longus, or only the extensity. I have shown the 3 cases like that. And it can sequentially involve from upper limb plexus to the lower limb plexus. Just like the girl which I have shown. And can also involve the phrenic nerve. So all these patterns I have shown. Okay. Any questions? In fact, Parthasarathi wanted me to talk about these various type of neurologic amyotrophy. That is why I chosen these various cases.
Excellent cases.
Okay. Thank you. Any questions?
Sir, do you usually prefer methylprednisolone IV or oral prednisolone?
Yeah, I prefer methylprednisolone.
Thank you.
Thank you, Butch. So shall I stop here? Any questions in this case? There is one more case. I think it will take time, but it's already only 10 more minutes is there.
Seems that all age group can be affected in this neurologic amyotrophy. There is no age or sex predilection.
No age or sex predilection. But very often what happens in that, I have 2-3 cases, the gynecologist blamed because of this thing, because after anesthesia, the patient developed this palsy. But that is only because you to the faulty posture and like that, the gynecologist it is blamed. But if we look very carefully, the pattern is not in the plexus, it may be in the multiple nerves. That you can definitely tell this is nothing to do with your pressure pulse or anything, nothing to do with anesthesia. This is only neurologic amyotrophy. To get a good localization, tell that this is the nerve pattern and not in the plexus pattern, you can be very definite.
Okay, sir.
Yeah. Okay, then, shall we close?
Thank you, sir. Thank you.
Okay, thank you, sir. It is very informative.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.
Good night, sir.
Good night.
Good night.
Thank
Thank
you
you,
very much,
sir.
sir. Thank you, sir.
Night, sir.
Good night, Bindu. Good night.
Good night, sir.
Good night. Good night.